Thank you for that. It's a very comprehensive and didactic lecture, I think very helpful for us. So we now go to the third presentation in this section. And our speaker is Nicole Mardešićová, who is medical director of a large group of IVF units in the Czech Republic, the Pronatal Group. She's also broadened her interest into management with an MBA from a couple of years ago and is active on Czech and ESHRE committees. So we look forward very much to your talk on PGT, whether it's past or future. Thank you.
Ladies and gentlemen, dear chairman, thank you for the kind welcome and for pronouncing my name right, because that's really hard for most of the people. So I think that we all feel that after everything that has been said yesterday and today, there is a thin red line going through all the lectures, and that is that we are lacking evidence. We don't really know if things that we offer to our patients really work the way we think they do, because you find so many conflicting papers, so many conflicting evidence. And unfortunately, my talk will be no different. Right now, I have to tell you, I won't give you the answer if PGTA is the past or if it really will be the future, because I don't think we can say this. I don't think that one approach fits all is really for all, because we women, we are very complicated, you know. And so I don't think you can fit one approach to everybody. When it comes to PGTA, I think we all feel that throughout all the add-ons or adjuvants, call it whatever you like, PGTA is special in one way, and that is that it is very demanding. It needs skilled embryologists, senior embryologists, very good vitrification program, and then we can add the transfer technique and everything else, and then we get lost. So PGTA is much more demanding than other add-ons. Let's call it add-ons. The field of reproductive genetics is very broad. There are so many things you can test when it comes to genetics, and I don't think we will test less in the future. Especially in my bubble, my social, demographic, political bubble where I move myself in, people like genetics and they demand genetic testing more and more. Preconception counseling, PGTA, MSR, NIPT testing of the fetus, donor gametes testing. Well, basically, genetics is becoming more and more part of our life. And I think it will be the same with PGT, probably. There have been many ways how to examine the embryos. We have moved from the polar bodies, then cleavage stage biopsies. I think that we all would agree, as Professor Sharara said, that the biopsy of a trophectoderm should be a uniquely preferred method. Of course, all of these are bound to assisted reproduction only. I will not mention PGTM or PGTSR, because I hope that we all agree these two are non-negotiable. If I have a monogenic disorder, my partner has it as well, PGTM is a must. Yeah? So we will talk only about PGTA, which is conflicting. There have been many publications. This one is the one that we all probably know, and this is the ESHRE recommendation, the guideline. You can still find the three possibilities that you have, and this is just my personal view. Polar body biopsy makes no sense to me, because then you get only 50% of the information, then the sperm comes in and everything is different. Cleavage stage biopsy, well, it is complicated, because if you have an 8-cell embryo and you take 2 cells out of it, first of all, the results are very conflicting because you get a lot of mosaicism. And second of all, of course, you can harm the embryo, even if you are the best one doing the biopsy. So we will stay with the blastocyst biopsy. And I know this is demanding as well. We come back to the beginning, because if you want to do the blastocyst biopsy, you need to work almost every day. We do. We work 7 days a week, so we don't care. But in centers that do not work 7 days a week, you need to plan the biopsy. We do the biopsies 120 hours. Sometimes when the embryos are slower, we wait till 144. But if you don't work every day, this is a challenge. So you need to deal with that. So I understand that as well. And that's one of the many reasons why PGTA is so complicated. This slide is, or this picture, the scheme, is from the ESHRE recommendation as well. And what I think is the most important thing in this slide is this: counseling. There needs to be a lot of talking done when you discuss PGTA with your patients. My father has a very nice saying. He says, "You can't see into watermelons and women." And that's right. We have a very wild, emotional life within ourselves that nobody can see. And when you consult such a problematic thing with your patients, there needs to be a lot of talking, a lot of honest talking done. We don't need to say that we know what we are doing perfectly. We don't need to claim that PGTA will save their future and it will give them the family they want, because that would be a lie. We just need to be honest, but we have to be very detailed. And if you are, then this will protect you from a lot of problems later on. I will show you. So what we usually tell our patients is that PGTA will detect the newly developed chromosomal abnormalities. That's clear, right? We will analyze the chromosomes. Then there is the big talking, what is a chromosome, what is a gene, and so on. You have to do the talking, but we talk about that. Whether it's NGS or karyotype mapping, that's not important. Then we said, for a very long time, we will or we might exclude fetal impairment, that we might reduce the risk of spontaneous miscarriage, that we will increase the chance of embryo implantation in the uterus after embryo transfer and shorten the time to pregnancy. But is this really true? And that's the problem. We don't know, because we are lacking the evidence. This is the ESHRE guideline, consensus documents and recommendations when it comes to PGTA. And the statement is that the current methodology for PGT shows limited improvement in live birth rate. Well, of course it does, because PGTA, as a diagnostic tool, will not make your cohort of oocytes better. Your oocytes are still your oocytes, so they won't get any better. And PGTA is just a diagnostic tool. So this is clear. What we thought would work is that we thought that we will reduce time to pregnancy significantly, because we will skip all the embryo transfer that are not worth doing, and that we will reduce miscarriages. Well, unfortunately, this presumption has been made on post hoc analysis, and therefore we need a lot more evidence. We are lacking evidence as well. The usually used indications for PGTA, and we use them as well, because Pronatal Group sends data into PGT consortium, are advanced maternal age. That's probably the most common one, right? Repeated miscarriages, repeated implantation failure, severe male factor, donor cycles, previous abnormal pregnancies, and then let's call it on demand, where you really don't see an indication. As I said, the most used indication is advanced maternal age. Now, you all know the picture, the graph here on your right side. As we get older, the results of ART get worse and worse and worse. And we know that the problem is in the oocyte, because we know that it works with the donor oocyte. So the problem is the oocyte, it's in us, okay. But let's be finally gender correct. And let's look at the other side of the table, of the picture. The graph that you see on the left shows you the predicted probabilities of live birth according to male age, stratified by a female age. And it's a rather busy picture, but you don't have to follow it really. You just see the trend going down. So the problem is even bigger, because we get patients that are older and older. But she comes with an older and older partner. So then you have a duplicity, you have a double problem. They are just way too old to have an offspring sometimes. And prolonged cultivation, 120 hours, sometimes 144, is a great way for selecting embryos. I mean, the ones that don't make it into a blastocyst, they just don't have the chance. But it is not perfect. As I said, you don't see into a watermelon, a woman, and into the embryo as well until you do the PGTA. So we know that even if you have the best-looking blastocyst morphologically, it has a 56% chance of being euploid, which is good, not 100, 56. On the other side, if you have a very poor-looking embryo, it still has 25% chance that it is euploid. So you can't really tell if the blastocyst that you have under your microscope is the one capable of giving you a healthy offspring. So what do we know, really? There is a lot of papers about PGTA. You get lost. Whatever database you look at, you get a lot of data. Let's start, for example, 2018, fertility, sterility, committee opinion of the American Society for Reproductive Medicine and Society for Assisted Reproduction Technology. And the result was that the value of PGTA has yet to be determined. That's not very helpful, right? 2020, human reproduction. This was a paper published by a Czech group, so you understand that I had to mention it. And what my colleagues did is they did a rebiopsy of embryos, and they wanted to see what's the concordance of the results. And it's quite expected. The euploid and whole chromosomal complex abnormalities, they're highly predictive. So if you have a euploid blastocyst, it is euploid after a rebiopsy. If you find complex abnormalities, those are there even after a rebiopsy, which is important. I will tell you something about the lawsuit going on in the US, because one of the problems that is stated is that we actually hurt our patients because we are discarding embryos that might not be bad. So this study, even though a small one, Czech group, you're not very famous, the Czech Republic, but still, the rebiopsies, they give you a good idea of how it is. The problem comes with the mosaic embryos, as always. Mosaicism, we don't know how to deal with it. So the mosaicism has a very low concordance day. So after a rebiopsy of mosaic embryos, they can be complex abnormal, or maybe less abnormal, mosaic, good for a transfer, very conflicting. So of course, the good practice recommendation from ESHRE. Everybody has seen, everybody has read, we know those. And then 2022, there was this paper that really divided the patients into the groups as the PGT consortium. And the results were that in the repeated miscarriage group, there was degrees of early pregnancy loss, an increase in live birth rate, but per transfer, not cumulative. In the repeated implantation failure group, increase in implantation rate per transfer and a live birth rate per embryo transfer. The advanced maternal age group, the blue one, sorry, I'm probably standing in a way, has shown a reduction in the biochemical pregnancy losses, but live birth rate per embryo transfer and per patient were not significantly higher. So there is a lot of fuss, a lot of sneakinesses when it comes to PGTA. And you know, patients are not stupid anymore because they have the ChatGPT, so they know everything. And this, and the change in human way of thinking has led to this lawsuit, which is going on in the USA, where patients are suing. Fortunately, not the physicians, not the IVF centers, they are suing Cooper Surgical, Cooper companies, Reproductive Genetic Innovation, Progenesis, Natera, basically companies that are making the sets and the tools that we need for PGTA. And the patients are saying that they have been misinformed, that we claimed that it is a proven safe method, and that is not true. Now, maybe I am too pessimistic. I personally think that everything that is behind it is just money. I didn't get pregnant, I want my money back. Correct me if I'm wrong later on, but this has nothing to do with medicine, this is just about the money. But it is happening, and this will happen in Europe very soon. They won't wait too long in Europe, they will start with the same things. So now I will open my heart to you, I will give you my results from Pronatal, which is my life. But before telling you the results of our PGTA program, I don't think it would be fair to show you the PGTA program without telling you who we are. Because if we were centers with, let's say, 15% pregnancy rates in women under 35, then you know that something is wrong. The lab is not working, freezing program is working, whatever. So these are the European data. You can see the pregnancy rates after IVF and ICSI. Throughout Europe, there are 27% of cycle with conventional IVF, 73% with ICSI. Well, the situation in the Czech Republic is different. We do 93% of ICSI cycles. You can throw stones at me afterwards. This is how it is. So this will be a little different. Frozen embryo transfer success rate and egg donation. And these numbers, because you have to say this as well, when you're talking about success rates, you have to ask the questions, okay, how many embryos did you transfer? 1.8. So this is the European data. In our group, we transfer 1.2 embryos. And the success rates are basically the same as the European success rates, 38% after ICSI, 37% after a frozen embryo transfer, and 53% after egg donation. So this is who we are. This is basically the same thing, so let's not waste time. So I counted all the PGC cycles only from one of our clinics, and I will tell you why, because I wanted to really know what I should tell my patients. It's great that we are talking about all the stuff here, super, but then you go back to work on Monday and you have to say something to your patients. So I wanted to know where I'm standing, should I recommend it or not? So I calculated. Only from one center, where all physicians were educated by me, we are having the same standardized operational procedures, we are doing everything the same way. Different hands, different embryologists, but basically this is as good as it gets. So you can see all the numbers, 325, only PGTA. Other PGT, MSR is excluded. 50% blastulation rate, failed amplification 0.6%. And you have to say this in the counseling as well. It can happen, then the DNA amplification will fail, yeah? So in this group, and this was the whole PGTA group, undivided, we had 40% of euploid blastocyst, 50% of aneuploid, 10% mosaic. Now we transferred 88% of the euploid and 12% of mosaic embryos, because we really do not discard the mosaic embryos unless the mosaic is greater than 80%. So we don't harm the patients. Now the results. Pregnancy rates per transfer were 60%. Out of these 60%, 95 were clinical pregnancies. Abortion rate, 15. So this is somewhat lower than in the normal population, but it's not zero. So we really can't say that we will have zero abortion rate with PGTA. Now in the mosaic embryos, it was completely different. The pregnancy rates were the same, but 50% abortion rate. I mean, it makes sense. They are mosaic, they are not euploid. But still, this is quite high. Counseling, 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 then you get out of trouble. Out of this whole group, 25% of my patients did not have a transfer. That means they didn't have a euploid or mosaic embryo for transfer. Now, then I looked in the advanced maternal age group only, so only older women. The results are, of course, different. We had only 19% of euploid blastocyst, 75 aneuploid, and only 5% mosaic. Maybe if we did the, how is it called, single-cell sequencing, the mosaicism would be a lot higher in the other group as well. We transferred 80% of euploid embryos, 20% of mosaic, and success rate 53%, abortion rate 14%, so it's basically the same all the time. In the mosaic group, it was 41% of pregnancy rates per transfer and 28% miscarriage rate. What I wanted to see is I looked, only almost half of the patients in this advanced maternal age group have no transfer. They don't have an embryo. And you have to tell them because that's a lot. Every second patient will have no transfer, no embryos good for transfer. Then I looked how it looks in the group of repeated abortions, because this group really benefits from PGTA when it comes to abortion again. The pregnancy rates were 75%, abortion rate only 8%. And that's already a significantly better. So I said that the mosaicism, we keep talking about it the whole time, that's a real trouble. We really don't know what to do with it, because with single cell sequencing, there was the study, it was mentioned yesterday, I think, almost 80% were mosaic, so probably the mosaicism is a lot higher than we think. We don't really know what to do about it. And as I said, we transfer embryos up to 80% of mosaicism. And if we have only mosaic embryos, no euploid, and we have more of them, which happens, then clinical genetician will say which one is to start with, second one, and the last one, depending on where the mosaic is. Different centers in different places is dealing with mosaicism in different ways. Some centers don't even transfer mosaic embryos. Some would transfer euploid with mosaic together. So we don't even have standardized procedures how to deal with mosaic embryos. We don't know how many are mosaic. We don't know how to deal with them. Obviously, everybody is doing something else. This is a busy slide, but you will find it in the ESHRE recommendation, so you can look at it, how different centers, different part of the world deal with mosaic embryos. So to conclude, PGTA is undergoing an expansion. It has many sneakinesses, as I told you. The problem is that you need skilled personnel, you need to plan the cycle so you can do the biopsy in the optimal time. And nowadays, I think that since genetics is evolving more and more, we get information that are problematic for us because we just know too much and we don't know what to do with that. For me personally, and I suggest that you do this in your centers with your own data as well, it makes sense to do PGTA in my patients. But I have to counsel them very properly. I have to say them that many of my patients will not have a transfer. But especially in the advanced maternal group, if they do have a transfer, then their success rates, their pregnancy rates, will be the same ones as in couples in optimal reproductive age, which is not that bad. And I think that mosaic embryos really shouldn't be discarded automatically, because if we do that, we will probably get in the same trouble as the US did. I was a little bit longer, sorry for that. Thank you for your attention.